Lindsay and Lara, thank you so much for joining me for this conversation that I've been dying to have with you both ever since my trip out to Sedona, where you held the first retreat for the Trauma-Informed Pelvic Health Certification course. I have to say this, and I wanted to actually give you this feedback just live because I had never talked about a course or a retreat or anything that much. And we're now spending our baby moon. We chose to go back to Sedona and either repeat that feeling or the aura or the energy or whatever it was that I felt at your retreat when I attended the Trauma Informed Pelvic Health Certification training. It's still to this day. I just said, Jenna, we have to do this. We have to go out there. We have to spend kind of our last vacation before baby comes and really just try to recreate that feeling. And so I'm so honored to have you both just to talk about why you created that program, why you created a certification that helps therapists in the pelvic health realm really understand what trauma informed care looks like, uh, and then how you brought us all together and just really pick apart a few of those things that I took away from that training to really direct towards maternal health, for birth recovery, for all of the things that we're doing. Just first and foremost, thank you both for being here.
Thank you so much for having us, Rebecca, and those kind words. And I'm so excited for you and Jenna. Sedona is just such a magical place. So it's the right place.
Definitely the right place to have a baby moon.
I completely agree. So what was the inspiration? Why the trauma-informed pelvic health certification? I've been trained as a pelvic health therapist for over a decade now. I had never experienced anything like that. Why that?
Such an excellent question. First of all, I just want to say that Lara was an absolute dream person to have this collaboration with. It came out very organically between the two of us, and it just from the moment it started, it was a dream collaboration. And I'd love to hear the way Lara's going to answer the question, but for me, it was deeply personal after working with over a decade with people that have pelvic floor issues. And we know that trauma affects, I think the latest statistics are 1 in 4 women and 1 in 6 men, meaning really a significant portion of our clients carry trauma history, could carry trauma stories. And I think that when pelvic health treatment involves intimate touch, it involves vulnerable positioning. And I think our traditional medical model really emphasizes clinician control. It really emphasizes lack of explanation, rushed procedures, a really implicit consent versus explicit consent. And I think over my years of being a pelvic floor therapist, I really saw that the nervous system connection, that trauma literally lives in the body and particularly affecting autonomic nervous system that controls pelvic floor function. So we see things like hypervigilance, chronic tension, protective guarding patterns that are mechanisms that are deeply associated with pelvic dysfunction. And without addressing these things, these underlying nervous system dysregulations, purely biomechanical approaches really fail. And so I know that both Lara and I deeply feel that trauma-informed care prioritizes establishing safety first, explaining to the T everything that happens first, consent every step along the way, offering choices around simple things like positioning, draping, really recognizing that healing happens within relationships and trust, not just through technique.
I will echo everything Lindsay has said and just how privileged I have felt to work with her to create this program. For me, the importance of it kind of came about from having experiences in my practice. So I'm an OT based in Ontario, Canada, where we don't have internal work within our scope of practice. And we don't tend to do a lot of manual therapy as OTs, but became really interested in pelvic health. And when I started my practice, ended up attracting a lot of folks who did have a trauma history because they were avoiding pelvic floor therapy. Internal work, hands-on work wasn't accessible to them. So I was able to kind of see the value of using my background in mental health, of addressing the nervous system and making really impactful changes in terms of how folks were relating to their body and seeing changes in their pelvic health symptoms. And sometimes that meant some scaffolding to then get them to a place of safety where they would feel comfortable with some of the hands-on work with a trauma-informed pelvic health therapist, if that was indicated for them. I was starting to hear amongst my colleagues, trauma-informed care starting to be talked about more and more, but it was being talked about through this lens of, we know it's important in pelvic health. We know it's showing up. So trauma-informed care really needs to be about identifying it, screening for it, and getting folks connected to trauma therapists. So it was feeling really siloed, where it was like, can I get folks connected to a trauma therapist so they can address their trauma over here? And then let's get back to pelvic floor therapy. So to echo what Lindsey was saying, is I was kind of seeing all of the ways that trauma could show up in so many ways when we were trying to address someone's pelvic floor symptoms. We can't silo it out. It needs to be more than just kind of that screening and those referrals. It needs to be integrated into the work that we do. And Lindsey and I were so aligned with that mission and kind of making it foundational and accessible to therapists to be able to feel confident in having those skills to bring it into their care.
What's phenomenal about what you just said, the integration part, not just the referral. I mean, Laura, I think that's really why I reached out to you all, is because I'm a physical therapist. You two are occupational therapists. And I was trained in the biomechanical model. And that's how I trained practitioners in the acute care space, which, Laura, they completely align with you. There's not internal work in the hospital, right? On the maternity unit. And so the acute care therapists that we were receiving, one OT in particular, she had completed her capstone, Doctor of OT, and she reached out to me, which prompted me to reach out to you both. And it was right around the time I attended your retreat. But she wrote this incredibly impactful email. I'll share just some of the details because it did, probably involved a little bit of client sensitive information. But she was involved in a treatment with a patient who had just delivered shortly after C-section, and unfortunately had an episode where she collapsed in the hallway while they were walking. This was someone who was going to be discharged pretty shortly after the occupational therapist did her evaluation, and just revealed that just even a short walk that she would have done around her home, maybe caring for her newborn, she wasn't quite ready to do. And the team would have missed that. And the OT expressed not really just the shock of the treatment, just kind of how chaotic everything was. It was more of, I love your course, Rebecca, but I feel like there is just a piece of me that's getting lost in the care of these patients. One, we're undervalued on the maternity unit as acute care therapists, as occupational therapy practitioners on the maternity unit. A lot of people still don't know what we do. And I'm seeing moms in situations that they really shouldn't be in with the limited support that they're given, and the lack of providers that really do believe them for what they're going through. And I said, I need some help. I need some help, right? And so I've reached out to you, and I would love for you to just maybe explain what you thought in terms of the certification program that you created could really translate well to the maternal health population.
Well, I think one big piece that stands out, especially with that example, is there's so much going on for folks as they are in the hospital, as they're giving birth, as they're undergoing all of these medical procedures, where there's the potential to have an experience that's too much, too fast, and too soon, and overwhelms their nervous system. But the other piece is it's often so fresh and raw when we're looking at acute care populations that it's doing some of the cognitive and conscious processing of the experience, identifying it as trauma. We're often not there yet. And so one of the core kind of components of trauma-informed care that we support clinicians with developing in our course is this idea of attunement, of being able to kind of be with and read the subtleties of someone's nervous system and how a trauma response might be showing up for them, so that we can recognize what's happening and when it's happening and respond in a way that holds space and promotes safety for that, but also attunement with ourselves. Like, we are a human with a nervous system that is showing up to these situations as well. And witnessing this stuff leaves an imprint on our nervous systems as well. So a core piece of trauma-informed care is also clinician care and monitoring for our own burnout. Yes, knowing when advocacy is important, but also knowing what we have the capacity for in terms of that advocacy and being able to gauge for ourselves when we can take that on and when we need to take a step back and prioritize our own self-care in that too is just such a critical piece of trauma-informed care that often goes unrecognized when we're just focusing on how that all of those potentially overwhelming experiences are impacting the clients and not giving ourselves space to process it too.
I remember that was one of the assignments. And I'll be honest with you, during the retreat, out of all the things that we were doing at the Trauma Informed Pelvic Health certification retreat in Sedona, I struggled with that assignment the most. You both sent us out. I remember I chose like a place in the garden under a tree because I felt like I could focus there. But that was like kind of an activity where we were mapping out our own process of self-care for burnout, essentially. And me trying to understand even the difference between like burnout and empathy or
Yeah.
strain, empathic strain, right? And I was just like, my gosh, this is really hard because I've been in both situations where I knew I wasn't feeling the burnout that is just described of us. Like I still felt empathy, but I didn't feel supported by my system, right? To take on the changes. And I felt like I had to just wheel and deal, in order to get things done, get patients seen, all of it. But that was such a hard assignment because of the self-reflection piece. And I just realized there were so many holes in what I was doing and training therapists to do because it was just very biomechanical. Someone has a C-section, someone loses a tremendous amount of blood, someone has limited support going home after birth, maybe they're a single parent. Here are the things that you do, here are the step by step. And I was missing the whole conversation that was taking place in that person's head,
Mm.
forgetting to really guide therapists and what questions to ask and all of it. And I think for me, I would love to know just from you both for those therapists that are feeling that either the strain or burnout, what were some takeaways that you felt from the trauma informed pelvic health certification course were important to put in the course that you created for maternal recovery?
Yeah, what comes to me, and I really appreciate you bringing up that was a challenging exercise, Rebecca, because I think that's what most of our students find. Even I went through the exercise myself, and I think it's because I think as therapists, we're so used to showing up. The empaths that we are, we often put ourselves second, third, and fourth. And so, even recognizing that this is a worthwhile activity, that we're not just rolling up our sleeves, but we're pausing and reflecting and putting the pieces together for our own lives. For me, I know there was a breaking point when I think the expression is the world got the best of me, my family got the rest of me. It's some expression like this. And that's when my husband had looked at me, and this is my first few years of private practice in New York City, and said, "You're not coming home the same person. I know you love what you do, but you're not coming home the same person." And I felt that myself, and him just crystallizing it with his words made me really start to actually get very interested in trauma informed care. And so it was so interesting because I thought about it always in the lens of my clients, but I never thought about it in a lens of myself. And so some of the practices that Lara and I have in the workbook and even throughout the experience together, I think are, for me, the most meaningful ones are exactly the experience I just explained, which is recognizing when you're not able to fill your own cup anymore. And it's a little bit like, when we have a kindergartner and they kept it together all day. They kept it together all day and the teacher is glowing. You're getting great reports. You come home and your little person is a tantrum maniac, right? It's like they kept it together all day and now they need that comfort and support. And I was starting to go down that path. So I think the reflective exercises that we give throughout the course are, number one, helping us to identify when we do need to take a pause, and then scaffolding around exercises that we can do to advocate for ourselves, whether we work for ourselves or we're in a maternal unit or an environment like a hospital, to put some parameters and boundaries so that the ones that we do show up for when we get home don't get the rest of us.
There's a word for that, and I can really relate to that, Lindsey. We had that with our little guy, and his teacher sent me an article on the phenomenon of restraint collapse, which is like when we are holding it together so much in a more formal space. So for us at work, for our kiddos at school, then you get to the people you feel safest around. You're able to kind of let go of the restraints. And for me, that was huge in terms of not taking it personally. Like, am I doing something wrong in my parenting that he's a perfect angel by all accounts, but just is such an emotional ball when he gets home. So I would 100% agree with what Lindsey said, the value of like noticing for ourselves when we need to build in some resilience routines, when we need to set boundaries, when we need to build our own support teams around us, like to process some of the heavy experiences that we're taking in, our own mental health teams. But the another layer there that I'm getting more and more feedback from our participants that go through the course that was really important aha moment for me was the difference between empathic strain and what used to be called compassion fatigue. And so there's a shift now in the literature with compassion fatigue being used less and less often because it implies that compassion is a limited resource. Whereas Dr. Kristen Neff's research shows us that the more we practice compassion, the more capacity we have for it over time. And so I would say, and one of the difference and why we're moving towards empathic strain is because empathy is often a very automatic reaction where we're stepping into someone else's pain and suffering. And like with my kiddo example, I would take it very personally, right? That I would feel like I needed to fix it and put so much pressure on myself. And I was right in it with him instead of being able to step back and hold space for the pain, which is what we are doing when we're practicing compassion and self-compassion. So I would say we do weave into our program some practices that support clinicians with self-compassion and compassion as being very protective against burnout and against empathic strain.
This actually happened like really recently, but a therapist that I completely respect, she's now teaching courses to other acute care therapists, but just really anyone who's practicing in the home environment, who's seeing the maternal population specifically really early after delivery and even during high risk pregnancy. And because it's still really just a newer concept for surgeons to like refer their patients, after surgical birth, she encountered a physician that was quite rude to her, like, completely felt like her judgment in ordering a walker as a physical therapist for this mom who just gave birth felt like that was not necessary. And she kind of unloaded in a text thread that I was on. And, I'm thinking now about that restraint collapse. Is that what it is?
Yeah.
Restraint collapse, almost as if like, I know, like she had to explain to me because I was like, did you say that? Did you write that? The response that she had, but there's such either this compassion fatigue, this restraint collapse, all of it. And we're just throwing these terms out and we're not really defining them
Mhm.
each because if we did, I think the reaction would be different. We would have really the understanding as therapists who are really paving a way in this area, just like you did, Lindsey, by creating, the first OT practice in New York City, that treated pelvic health clients. It's like when you're hitting a wall and people are around you who love you and like know what's going on, how do you keep going when it's so important? But, with her unloading, I was just kind of thinking about that. Like, this is a phenomenal therapist, a phenomenal instructor. She's now doing contracts with hospitals to train their staff. And here's this surgeon basically telling her, no, your diagnosis, your evaluation, your assessment of this person and their fall risk means nothing. We don't give walkers to moms after C-section. End of discussion. And it's like, I'm sorry, I just spent so much time with this woman. I just spent so much time with this patient. This is important. And so for the therapist, and this just keeps coming up, and I'm now directing them, please take this course, with Laura and Lindsey. But for these therapists that are paving ways in pelvic health and maternal health, the terms that they should know are what in terms of caring for themselves?
Well, I think in order to kind of be able to recognize those reactions in ourselves, that's so valuable in terms of directing us towards what we need. And it might be, I need that restraint collapse. I need to vent to my people that I can feel safe to so that I know how can get it out of my system and then be really thoughtful and intentional as to how I want to show up to that surgeon and respond to that resistance that I'm getting. Sometimes that helps us kind of wade through the mud to be able to use the emotions to direct us towards effective action. And so the signs for us, I think that we might be really struggling, and the terminology, it might be empathic strain, which is that feeling really depleted because we're holding on to a lot of those heavy stories. Another term that often comes up and can be the case for us as providers is secondary trauma. So we can witness and receive kind of these experiences, and it can impact our nervous system and have much the same impact as the person who's having that experience more directly. So we can start to develop symptoms of post-traumatic stress disorder and burnout. And burnout is often more about what you described, Rebecca, in that I don't feel like I have any agency or have the resources that I need in the environment that I'm in to be able to do my job in a values aligned way, in a way that I can feel good about. The challenge is they can all look and feel really similar. And so the value of kind of doing that really hard work of taking a step back to reflect is we can start to tease out what are the things that are contributing to this snowball for me of feeling really depleted, of feeling really burnt out, so that I know what those factors are, because that often points us towards what we need, right? What sorts of supports we need or what we need to do to ourselves to start to put our own wellness.
For me, I think a little bit about the layers there, Rebecca, and the question that you gave us, because my first reaction is to think about the client in front of me and sort of the story and the experience that I'm carrying and that I internalize as I'm showing up to serve them. But then in the story you gave, this is another whole layer, which is the physician discounting a credible piece of advice that through our clinical reasoning we deemed necessary. And I think that's a whole nother layer here that brings out deep feelings of imposter syndrome and feelings where we're questioning our own authority now. And I think that this is sort of like a double whammy, which is a technical term, because now we're being squeezed from both capacities. And so I would also mirror everything that Lara said, and on top of that, kind of come to a place where you also can stand firm and confident in your area of expertise, because absolutely it was that person's right without question to recommend a walker. And so what that looks like in each system is going to be a little bit differently in the way they advocate to make sure that that parent goes home with that device. And then being able to come home and process those layers ahead of time. I waited until I got burnt out to realize it needed to happen. I would say anyone even embarking on this field, start to be aware so that you do not get to that place of depletion, but rather are more proactive regarding the ways that you might feel that squeeze and that strain and that pressure that kind of go against your ability to show up and serve with enthusiasm, which is exactly why we all got into this field to begin with.
Absolutely. With enthusiasm. I mean, that completely, like, I just want to emphasize that is that we've been so passionate really in the work that we're doing, especially the therapists that are just paving again, really new pathways of recovery in their own communities. Like pelvic health is still not a household name, you know, in both of our disciplines with occupational therapy practitioners or physical therapists. And neither are these really niche areas of maternal health where we're really trying to train more therapists to be empathic, but resilient. I'm now starting to really despise that word just because it just gives almost a sense of like, I'm bulletproof and I'm not. right? So I don't want to use that word, but really, for lack of a term, is just giving grace to ourselves, and also giving grace to our families. When we come home after wearing our Superman or
Mhm.
Superwoman cape all day. But really, I want to bring this full circle with a lesson that I learned from you, Laura, and please, if you both can speak on this, it was almost projecting. What I would say, I was probably projecting the most when I did have a patient that I thought this was a traumatic birth. This was a traumatic experience. And then another patient where I thought, okay, well, this was a mild perennial tear, this should be fine. And it wasn't. I mean, it was just, to me, I was really thinking about the lesson that you gave in the trauma informed strategies for maternal care, was that we can't almost project, or we can't, already label someone as having trauma without actually speaking with them and without actually evaluating and assessing who they were, and what happened and what it was, or what their experience was in their own words. And that was completely mind blowing to me. Is there a way that you can maybe bring this together for people who just don't understand what do you mean? If I read it in the medical chart, this was trauma. How can you explain to someone that you can't really actually perceive what trauma is just from a medical note?
Right. Yeah. Um, I think the best way to explain it is if we look at trauma as not just what happened to the person, but how also what resources they had. What was their support system like? Did they feel like they have the resources to cope with that event, that experience? And that's where we talk about these kind of key principles of trauma informed care as being really transparent and clear and prioritizing the person's narrative and experience of what happened over kind of protocols that is so protective against having a really significant medical event imprint as trauma on the nervous system. And so we can't really label something as trauma without exploring the impact that it had for someone and their lived experience of that event.
Completely agree. Wow. And you're talking to someone who's creating protocols right and left, to, to be in alignment a lot with our referring providers, right? That's the language of a surgeon, is a protocol,
Yeah.
right?
And I think those are so important, right? Too, to kind of anchor us. It's just and you shared with us this really incredible kind of New York Times video on managing pain with C-section, right? And one of the things that really struck me with that video in terms of then the UK's recommendations of how we manage pain with C-section is if we're prioritizing the protocols over someone's lived experience, that's where we have the potential to do harm or recreate trauma. Whereas if we can kind of put them more even ground and even prioritize that lived experience a bit more and still use those protocols, there's so much utility to that. But it's how much weight we give them, I think, that gets a little muddled.
I was blown away by the UK's just their response. First of all, just to everything, is just like, oh my gosh, can we please bring some of that over here to the US? But the report of just over 8 to 11% of the patients who undergo a C-section could feel their surgery during the procedure, could actually feel what was happening automatically. That's pain science. That's something that we should all be trained on. I mean, that's an obscene number of people during surgery who could feel their actual surgery. And what was interesting really about that whole report was just the recognition by every professional involved that this kind of thing was not new. It was normalized. So different. It was normalized not only even by the medical team and the anesthesiologists who knew, these medications or anesthesiology interventions were utilized over and over, even though the fail rate on them was so high. It was normalized also by the patient. Like women weren't actually speaking up. Even first time primary C-section moms undergoing their surgery, they weren't actually speaking up, but then would talk about their trauma in this wonderful report that was done by the New York Times through a podcast called Retrievals, but they were actually able to process it later. And that kind of just brings me really to the close of my conversation with you is there space for us really in trauma-informed rehab for the maternal population? Is there space for more professionals like rehab therapists to be with this population after something like that?
Sent.
Undeniably, I mean, it's one of those things where I go back to why did these mothers not feel comfortable speaking up? What was the environment that was there that you couldn't raise your hand and say, no, 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 something is wrong? And I think that speaks to sort of the over medicalized white coat syndrome that we're in. And so one of the things that I know, and full transparency, my background is really in the outpatient sector. I haven't done much work in acute care at all, which is really emphasizing agency and explicit consent, which is something that Lara and I teach over and over again in the course, because how many medical situations are we in where we're told where to sit? We're not asked our thoughts or our opinions on anything. And so one of the things that I think is such a privilege in teaching pelvic health is to emphasize what it feels like when you have a choice. And I think the more that we can give our clients what it feels like to have a choice, the more they're going to demand it. Rebecca, you have said this before, and it's always stuck with me. The consumers have the most power. And when we start advocating for ourselves what is right and what is wrong and what we feel comfortable with, now this is going to be that ripple effect that we so deserve to see. And so I like to empower every single pelvic floor therapist that studies with us to be aware of that ripple effect that we have, even in a 45-minute session together. Because once you feel that in your nervous system, there's no going back. That is medical care. Right. And so, yes, I think there is so much room and so much growth. And I'm so grateful for conversations like this and collaborations like this with Lara, because we are changing the story. We are changing the future of what should be so that people don't have to experience these things anymore.
A MedBridge consultant that we're working with now on what's called the birth recovery pathway actually said, if you want to change the story, you have to change the storyteller. And what I'm realizing now from your course, ever since taking it, first of all, you open it up to other practitioners. Like you open it up to me as a physical therapist to learn what you all are trained on in mental health as occupational therapists, but then specific to the pelvic health population. I never saw anything like this. I never saw training like the Trauma-Informed Pelvic Health program that you created. And then to really understand how to change something that you said, Lindsey, why couldn't they raise their hand? Women are strapped to the table. They're strapped literally physically to the table, to the operating table when they're having a C-section. And if they're screaming, those screams are ignored in an emergency cesarean birth. And so all of that, like what you're saying is absolutely right. But just almost inherently for some of us who would speak up, we can't, or we're not even heard or even given another opportunity to just be put out so that we're not having to experience that and be conscious through it. And so that's really where I think my most important question for you all is, do you have space in the future? Is this going to be a program that's going to go year after year? Can therapists find about it, somewhere and get the training that you're offering? Because we're seeing now pelvic health clients in every setting. We're not just outpatient therapists anymore. We're home health, seeing the pelvic health population. We're inpatient providers, acute care therapists seeing the pelvic health population. We're virtual care providers like I am now, treating these mothers within a few days of going home and having to intervene of whether or not, we need to actually go back to the hospital, because I'm seeing so many more things now and just virtually where they're comfortable receiving care, but it's hands-on, is mental health caps on. And we're seeing these patient populations again in our outpatient practices where we historically have seen them. But we all need this. What you've created, we all could benefit from in pelvic health. How do therapists find out about the program that you've created?
So Laura and I have made the decision to offer it a few times a year now. So in the past, we were just going to offer it once. And as you know, it was associated with an in-person retreat that you were able to come to, which we were so appreciative of. I think the model we're moving towards now is to offer it twice a year, and to have a retreat, an optional retreat, potentially every year, every other year, where we can come together and really do a deep dive where we get the benefit of being in an incredible environment with each other in community to really, really do a deep dive on this. As fortunate as virtual care is, I'm a big proponent of it. There is something special about stepping out of our usual environment and taking time to be in community. So we're looking forward to that. We're actually this is the first week, second week in September. Doors are actually open this week for the program. And then we're going to offer it again in February 2026. And you can find more information about it on my website, which is functionalpelvis.com/trauma.
Oh, I'll include that in the show notes today. Lindsey and Laura, I cannot thank you enough. Selfishly, I hope the retreat is open to past
Of course. Absolutely.
And even if it's not in Sedona, what you've created really can just be replicated anywhere around but there's something special about that place, you guys. I mean, there's something so special about Sedona. What is it? The vortex?
Yeah, the vortex.
Okay. We'll be experiencing all of that on our baby moon. So
Yes.
Trauma-Informed Pelvic Health Certification Program is open to providers who practice in pelvic health, but I think that really any provider who has a touch point with the maternal health population, with someone who's had a women's health procedure, who has a touch point with people who historically are just not heard, within their healthcare experience. I have to say, I have to put a plug in. If there's an application process where, could they, potentially go through that, just to have this knowledge and education that really should be at the foundation of both of our disciplines in OT and PT school. I just believe that what you're doing, you're transforming lives through so many of us who have touch points with people throughout our career. Thank you so much for what you're doing.
Thank you.
Our absolute pleasure. And just one quick thought that sparks something with what you just said, Rebecca, which is I do believe this work should be at the master's, PhD level, because the thing is, we sort of bare knuckle it. When we're in that level, we're willing to do anything. We feel such a strong calling. And then we get out and we hear the stories and we fall asleep at night replaying them over and over, unequipped with really how to show up better the next day and to sleep better that night. And so I really do believe that this work, whether it's for pelvic health or not, needs to be a core part of every rehab program, honestly, every allied professional program where we feel such a calling, and that empathic strain is an absolute likelihood, just given our nature and given what we're surrounded by. So I agree with you. And I hope we see that change in our lifetime.
Totally. And I have to just say the last word on this. If you ever wanted to make the retreat kind of its own thing, for those of us who just want to come again, I know that you'll take me because I'm begging you on air. But really, I mean, just again, Laura, I've seen, you now in person at the OTs and Pelvic Health Summit, right? So you already know how head over heels every time, every chance I get, I talk about the OTs and Pelvic Health Summit. It's my favorite pelvic health conference of the year. But I think truly the retreat was its own special sauce. I mean, the time and the intimacy of that conference, of course, I wouldn't want that to be changed. If you want a big conference with a lot of people, come to the OTs and Pelvic Health Summit. But the trauma-informed pelvic health retreat that you did, wow, if that could even be a way for people to just feed off of that energy, is such an intimate experience. So just kudos to you both. And thank you so much for everything that you're doing. Really, really, truly.
Thank you, Rebecca. We're so grateful for all the work that you're doing and for the opportunity to talk about this program.
Same. We'll talk to you both soon.